Hi guys, this is finishing class 6 uh, and we're starting on, well, I have three slides to a page, and this is page 14 for me. Some of the things that when we're talking about moms and we need to teach them at the very first visit that they have for prenatal care, obviously avoiding the top things: alcohol, cigarettes, smoking, caffeine, drugs. We've talked about that before. They need to know what is a normal discomfort, what they can expect. As their uterus grows, there are going to be the round ligaments are going to stretch and they can ache. They're going to be voiding more. They may be leaking urine as the pregnancy goes on, but they also need to know more critically, what the potential complications are. So vaginal bleeding, sometimes vaginal bleeding because mom's cervix gets friable when she gets pregnant. Remember, that's easily roughed up. She may have some vaginal bleeding with intercourse, and it's perfectly normal, but always to be safer than sorry, vaginal bleeding should be checked out. Painful urination, we know we want to keep mom from having a UTI because of preterm labor. And then the hyperemesis gravidarum that we talked about, that excessive vomiting, where mom can't keep anything down, and so she's getting dehydrated and her electrolytes are getting off. So that is not a good deal either. All right, she needs to know how to recognize preterm labor. If she is having a regular backache, if she's feeling cramping, she needs to come in for sure. And let's see, it's really important that moms get this information, then also get it in writing. So warning signs need to be there in writing, and we need to tell them. But obviously, if they're not sure, they can always call Labor and Delivery. We're open 24 hours, or call their provider's office. So usually there aren't any restrictions in sexual activity. And let's see, there's different positions that work better as mom's uterus gets in the way. So figure 14-18, page 330, has different positions for intercourse. And obviously no restrictions unless we have some preterm labor or bleeding that are going on. And then for a more complete list of common discomforts, you should look at table 14-2, pages 324 and 325 for those common discomforts. So, and then we're going to screen for depression, anxiety, always listen, answer questions, and then we also want to screen for intimate partner violence for sure. Okay, so here's a picture of mom in a seatbelt. Notice she's got her lap belt low around the hips underneath her belly, and then high, not over her belly in any way. There is a care plan on page 327 about discomforts and warning signs. You have to know the warning signs, and that care plan is on page 327. Major motor vehicle accidents are a major cause of death in pregnant women. What we see is, and it can happen even with minor crashes, that with that force that goes forward and then backward again, the placenta can tear away from the side of the uterus and moms can bleed to death. So moms who are in a trauma situation are usually considered at higher risk even in that trauma. Okay, cultural influences. There are lots and lots and lots of different variations in childbirth for sure. For some people, it's a normal thing and they don't seek care unless they're ill. They feel like it's a really natural process. And obviously, like we've talked about before, to have cultural competence, you can't know everything, but you definitely want to learn about the childbirth practices of the different cultures in your area. And if you find, you have somebody from Haiti or from Eastern Europe, obviously use your resources and you can look everything up. And these are the kinds of things that you need to look at as far as and assess as far as cultural influences. Okay, age differences. Adolescents, unfortunately, don't always receive adequate prenatal care. They may not be in a stable relationship. They may be afraid of what their parents are going to say. They can, after the age of 14 and later, they can have the first trimester of prenatal care without telling their parents about it. But after that, the doctor can't care for them unless they have a permission from the parents. So there's a care plan on page 332 and 333 if you want to look at that. We know that the United States has the highest teen birth rate in all the industrial nations. Also, because they're adolescents, we see higher risk behaviors, more smoking. Those adolescent moms, their nutrition isn't great, so they're not gaining enough weight. And so obviously, if you have lack of prenatal care, drug use, smoking, and bad nutrition, you have a higher risk of poor outcomes. And so that really, any adolescent then is considered a high-risk pregnancy. Women who are older than 35 years, and we see lots and lots of them, the age that women are having babies is going up and up. We're into our 50s now. Usually when they're older like this, they're more settled in their careers. They probably have a little bit higher education than an adolescent, at least. And if they're healthy, they have a greater chance of having a term baby with normal weight. But if you are older, there's increased risk of miscarriage and stillbirth, because we do see more fetal anomalies. And so that's kind of Mother Nature's way of getting rid of, we call it a blighted ovum or an imperfect cell. We also see, the other problems that we've been talking about: diabetes, high blood pressure, Down syndrome. Older moms tend to be at higher risk for C-sections and higher risk for chromosomal abnormalities, for sure. Multifetal pregnancies. Again, this is another high-risk pregnancy. There are lots of things that can happen. Definitely multifetal pregnancies are more likely to end in prematurity, where you have little tiny babies like we talked about last night. There can be lots of problems. We'll talk about the baby problems later. We see that spontaneous rupture of membranes before the babies are term. And then if you have a monozygotic twin, you do see more congenital malformations, and that's no fun, right? So we need to give special care to moms who have multifetal pregnancies. Again, they will have prenatal visits more often from the time we know that they have a multifetal pregnancy. We kind of look at a difference in weight gain and nutritional intake. So because there's a larger uterus, there is a greater blood volume. It puts more strain on the cardiovascular system, for sure. Let's see. If there are more than 3 fetuses and it's early, they especially do this if they've done some artificial, fertility treatments. They will usually they will do selective reduction. That shouldn't be reproduction, it should be reduction if there are more than 3 fetuses. So moms obviously do have a choice, but if you have more than 3 fetuses, the likelihood that you may lose all of them, it is much higher. Okay. And then having multifetal pregnancies when you've can place a strain on finances. It's very expensive. A lot of times moms will need bed rest early, even like 20 weeks early. And so that can be money problem, not being able to work problem, etc. I had a former student who had triplets a year ago, and they hadn't been, anyway, she had triplets. She worked until quite late in her pregnancy, actually, and now they have 3 babies, but you're buying 3 sets of diapers, etc. So they often need help planning for care of babies. It's already incredibly difficult to get daycare. So in Bismarck, can you imagine if you had 2 infants that you're trying to place? So helping them, referring them to different social workers is very helpful. And then there are groups of parents of twins and triplets, and there are good references on the internet also that we're going to send them to. We don't want them to feel like they're in it alone, for sure. Okay, so perinatal education, you can see the goal, and you need to know the goal. Why do we do perinatal education? We want them to be informed. Usually, the more mom knows about the process, the less scared she is, the less tight she is, and if a relaxed mom can have an easier time during labor. So let's see. Early pregnancy classes talk about exercise, nutrition, warning signs. In the mid-pregnancy, they start talking about breastfeeding and some infant care. And then later, after 32 weeks, we usually start seeing them going to Lamaze classes, learning birthing and breathing techniques, and even if they've had them before, even taking a refresher class to kind of help them. So Lamaze was the formal breathing, birthing, natural birthing class. And now most places don't necessarily use the Lamaze, but they do childbirth classes that incorporate those relaxation and breathing techniques that they use in Lamaze and kind of other things. Really important to make moms feel like from the beginning, whatever happens in labor is what was natural for them at that time. So they don't get hung up on having this beautiful, perfect birth, because it doesn't always happen the way they want it, and then there can be some depression and sadness afterwards. So the choices that we have, physicians will take care, OBGYNs will take care of all pregnant patients. Midwives will, and we only have certified nurse midwives, they will take care of moms who are stable, don't really have any high risk things, and they are trained to refer to a physician if there are any problems. Direct entry midwives, certified midwives, these are midwives who've taken a course above and beyond like their bachelor's, and this is what they have in England. This is what we see. A certified nurse midwife is going to be someone who has their master's degree and has gone on, done a residency, etc. And then traditional or lay midwives, these are unlicensed people who are used to, they they can take classes over the internet, or they can just think they think they know everything. But these are people who will come and deliver babies in homes. Usually certified nurse midwives are practicing in the hospital setting and in the clinic setting. Direct entry midwives, I know in England, they will actually go out to the homes. And then the lay midwives do not practice in a medical setting. A doula then is a different thing. Oh, and it's important to remember that traditional or lay midwives are not they're not licensed. They're not accountable to anybody. So if they have a bad outcome, unless they press criminal charges or do like a civil lawsuit, they have no accountability. They can't pull their license if they're not. When we talk about direct entry midwives, these are not even nurses always. They just, in the United States, they can just go to school and have some training. Again, that can be on the internet. So if they're not nurses, then our licensing body have no control over them. All right. And now in states may allow this, and they may, have to be certified by the health department, but again, not necessarily nurses. And then that certified nurse midwife is a nurse with an advanced degree. So doulas are basically a support person. Okay, they're like a hired birth partner to support not just the mom, but the couple during labor, before labor, during labor, and after labor, postpartum too. And again, these are non-licensed people. Anybody can decide to be a doula and call themselves a doula. It's not regulated at all either. And then birth plans are basically moms saying what their ideal birth would be. Usually we have forms to kind of let moms know what their choices might be, where they're going to deliver. It gives couples more control over the process, or at least feeling more control. Really, the baby kind of decides everything. And birth plans are nice because all of the admission questions that you normally do when a patient is admitted, that is all done before they actually come in labor, so they don't have to deal with all that stuff. And then hospitals, you can see the different kinds. We have labor, delivery, recovery, postpartum rooms, okay? Birth centers are usually freestanding centers. Usually they're close to hospitals, but they think of that as more a safer but home-like atmosphere. Only low-risk women can deliver there, and they must have a plan. They have to be within so many minutes of a hospital. And then home birth. It's very popular. People don't want to have medicalized, basically, births. They want to go back to the way things were years ago when people would deliver at home. I say back then, lots of moms and babies died, lots more, and that hospital births are safer. We would only use or have low-risk women do this. In the United States, less than 1% of women will have a home birth. Now, like I said, the certified nurse midwives in England will do home births, but they'll come in a van, they're set up, they have everything they need to, and they have the skills, knowledge, and ability to keep it at a very safe birth. But you can have a totally normal pregnancy and a totally normal labor, and at the head can be out, and then at the very last minute the shoulders get stuck. And what are you going to do then if you cannot do an operative delivery, or if the cord falls out in front of the baby? That's an emergency thing. So I would very much rather be 2 minutes away from an OR to have a C-section rather than a half hour. So, and put the baby at risk. Okay, with regard to follow-up visits and physical examination for women receiving prenatal care, nurses should be aware that the interview portions become more intensive as the visits become more frequent over the course of the pregnancy. Monthly visits are scheduled for the first trimester, every 2 weeks for the second trimester, and weekly for the third trimester. C, during abdominal examination, the nurse should be alert for supine hypotension. Remember what that is. D, for pregnant women, a systolic blood pressure of 130 millimeters mercury and a diastolic blood pressure of 80 milligrams mercury is sufficient to be considered hypertensive. So, there we go. What would be your answer for prenatal care? And we would say C. Let's see. It depends upon how often visits are going to be. It depends upon the pregnancy and any risks in the pregnancy. The interview portions are very long in the very beginning and then the visits are much briefer. C was our answer. We would always wedge to a left tilt, so mom's uterus is off that inferior vena cava, which causes a sudden drop in blood pressure. And then it depends upon mom's non-pregnant blood pressure as to what is going to be considered hypertensive. Okay, so this was class 6. The rest of class 6, and of course you're going to need it for the exam on the 26th. Any questions, let me know.